This conference will now be recorded.
Awesome. Well, welcome everybody. I'm so happy you're able to make it today to the Health Improvement Planning Steering Committee, which I have dubbed as the HIP Steering Committee, because we're all hip on here and hip on health, right? So this will be the first of 6 meetings we've got headed into December 31st when we can put that community health improvement plan out. So this is really exciting. We appreciate your time. We know everybody's so busy this time of the year and just catching up after COVID hit, trying to stay on top of everything and then heading into the holidays. So you guys being here really means a lot to us to help put this plan together for the next 3 to 5 years. So let's go ahead real quick with just some introductions. We typically don't do that on Healthy St. Lucie, but I think right now it'd be really nice with a smaller group if we could just do some introductions of name, organization, anything you want to talk about that you do as well, but real brief. And we'll just go ahead and start. And I'll go ahead and call people out so we don't have to all do it at one time. So I'll go ahead and start with Stephanie. You're the first person I see up here, and let you introduce yourself.
I'm Stephanie Myers. I am the Health Promotions Coordinator and with Florida Department of Health.
Laureen Sihombing, and I work at the health department and I wear mask hats.
And she takes the minutes for all of our meetings and it's phenomenal and we appreciate her so much. So, and I have Nancy Yarnell.
Hi, I'm Nancy Yarnell. I'm Director of Consumer Care and Planning with the Area Agency on Aging, and we manage state and federal funds for in-home services for seniors and caregivers.
Awesome. And Bridget?
Good afternoon, everyone. Bridget Lane, registered dietitian, public health specialist for the University of Florida Institute of Food and Agricultural Sciences Extension Family Nutrition Program.
Awesome. And Jen?
Jenny Bunton. Oh, sorry.
That's fine. Go ahead.
I'm Jenny Bunton, University of Florida IFAS Family Nutrition Program.
Oh, and Jim?
Jim Dwyer, Children's Services Council, St. Lucie County. We fund a variety of programs primarily aimed at children and families. I'm happy to be involved in this, but I'm going to turn my camera off so I can finish eating my lunch.
Thank you. Awesome. Patricia?
Yes, hi, this is Patricia Filano. I'm with the Florida Department of Health Title V program through CMS. We all have 3 initiatives: healthcare transition, integrated behavioral health, and patient-centered medical home that we focus on.
Awesome. And I'll do Catherine.
Hi, Kathy Register. I'm Nursing Director at Children's Medical Services. And in addition to what Patty talked about, our Title V program, we're also involved in medical foster care and the statewide CMAT program.
Awesome. Cherie?
Hi, Sherry Sickery, Treasure Coast Food Bank.
Awesome.
Care Coalition.
Okay. Cherie from American Heart? Are you? There she is.
I didn't realize there's a Sherry in here, so I'm Sherry. I'm Sherry Willison with the American Heart Association. I am the Community Impact Director, and I work on policy system and environmental changes around patients and access to care, nutrition security, tobacco and vaping, and specifically women's health as well.
Geez, I've just checked off a lot of the list of our community health improvement plan. Awesome. We're so glad you're able to join us. Emily?
Hi, I'm Emily. I'm with the Florida Department of Health in St. Lucie County. I'm over the SNAP education program, and I'm also dipping into the diabetes prevention program that we're starting here pretty soon in the new year.
Awesome. Kalita?
Hello, everyone. I'm just Kalika Scott with the City of Fort Pierce. I'm the Grants Administration Manager and Lincoln Park Revitalization Coordinator, and love working with the Health Department. Yay.
Awesome. I haven't seen you in person forever or even on video. That was fun. Yay. I know, right? Got to make this a little fun. Awesome. Sonia?
Good afternoon, Sonia Gabriel. I'm with the Florida Department of Health here in St. Lucie County, and I'm the Community Health Nursing Consultant, Nursing Supervisor from our Maternal Child Health Departments.
Awesome. Angela?
Hi, everyone. I'm Angela Alicio. I'm the Community Engagement Coordinator for Cleveland Clinic Martin Health.
Awesome. So glad you were able to make it.
Thank you for having me.
Yeah, we're so excited. Edgar?
Hi, this is Edgar Morales. I'm with the Florida Department of Health in St. Lucie County, and I work together with Jennifer and Stephanie in community health promotion.
Awesome. And I have caller 2, so I don't know if that's one of us that have called in and we're not on the thing, but is caller 2 there?
I think that's Lorraine.
Okay, Lorraine. Okay. Just making sure, just seeing if we missed anybody in the chat box that signed in, but I think we've got everybody there. Okay, perfect. So I am going to let my camera go for right now so I can move some stuff around. So again, thank you for being here today. I can't even tell you how excited we are for this planning process. I came on board in early 2017 after our community health improvement plan was already put together and our community health assessment had been done previously. So I got to kind of dive right into starting to implement that plan, which was a lot of fun. And it's been a great 4-year ride on all of that. I've had so much fun. So I love being in the middle of this process now where we're looking at where are we now and what do we want to do in the future. So being able to partner and work with you guys that are on the phone on coming up with this and developing this next plan is really exciting for me. So just a few housekeeping items about these meetings before we get going. And we've already talked about this, but the documentation is so important for us for our accreditation. So that if you do have your name, title, and organization in the GoToMeeting chat box, that serves as backup documentation for us when we create like a sign-in sheet that goes along with our meeting packets. That's really helpful for us there. So, and I just want to put a few meeting ground rules out there too. And you may have some that you want to put in the chat box that you don't see on the page today that we're definitely okay on adopting, but just some couple things that, you know, it's hard on these virtual meetings, but hopefully we can all work as hard as we can to stay mentally and physically present at the meetings while they're here so that we can make great decisions. And sometimes, hopefully, like I said, it was my email, that if we have 2 hours allotted, but if we don't need the 2 hours, I'm okay, and I'm sure you guys are too, that we don't have to take the 2 hours. We don't have to fill it. So I think the more mentally and physically present we can be here, the better. We're probably going to come up to some areas in future meetings where we don't agree on everything, and that's okay to not disagree, but we definitely want to challenge ideas constructively and not personally attack each other. I have never seen anything like that in this group. Maybe a few things that were on the verge of some things, but not anything so far in Healthy St. Lucie. But anyway, I just hope we can be really constructive with things. And then obviously when we present problems, if we have some solutions, that always helps to kind of keep that conversation moving forward instead of stopping the brainstorming and the conversation. So that'll be help. When confused, please ask. A couple weeks ago, I was on a webinar that I didn't have my slides weren't advancing, like I had actually turned it off, but I didn't know, and it was going in the chat box. So please just stop me verbally if you need to. I don't care if you interrupt me and talk over me. I'm totally cool with that. I missed the chat box message, and we may use acronyms. If there's anything you don't understand, don't hesitate. Even with Edgar yesterday, we were going over some of the data he was going to present today, and I didn't understand what that meant. So I had to ask him. There are no silly, stupid questions or anything. We all come from different backgrounds and have different strengths. So if there's anything that's confusing, please do not hesitate to just ask. And again, interrupt us if we continue talking. We want to hear from you for sure. And we're hoping that all members, are helping at this problem solving. And the last one, like, you have a unique perspective here. We want to hear from everybody, and we value all those different perspectives. And I know sometimes on conference calls, and I have a hard time just hearing. It's easy at a meeting with one person on the floor at a time with no interruptions, but it seems to be harder for me on conference calls when you can't really see who's going to talk next. So, but we'll try to do our best to make room for that and accommodate. So please, if we miss you because we didn't hear you or somebody was louder, we want to make sure we do get you, and we don't want to overlook that. So again, just don't mind being assertive in the chat box or assertive verbally to make sure we hear you. Anybody else have any good ideas? Anything come in the chat box about some other ground rules or anything that you all have used before that was really helpful? I didn't see anything coming in. Okay. No, you didn't either? Okay. So I know we've looked at this diagram a couple of times, and I don't want to overburden us with this, but just in case anybody joined today, just trying to understand what we're doing, we're actually doing a community health improvement process that we do every 3 to 5 years, looking at the health in the community and what are some of the best strategies and solutions for some of those health issues. We're using the MAP framework, which is a National Association of County and City Health Officials Best Practice Framework. The MAP stands for Mobilizing for Action Through Planning and Partnerships. And when we're done with that process, we end up with a community health assessment, which we call a CHA. And then we end up from the CHA moving into what we call a community health improvement plan we call CHIP. So if you hear us say CHIP and CHA, that's what we're saying. So we completed the CHA on June 30th. What we couldn't complete in that CHA was one of the 4 MAP assessments, which is the local public health system assessment. We've completed that collection now, and now we're in writing and analyzing for the report and finishing the report up. So we're so excited to have all 4 assessments done and ready to go. But what's kind of changed is we were hoping to have an extension on getting our CHIP done into next year, and we were told that all CHIPs have to be done by December 31st of 2020. So that is kind of like what we're moving into right now and getting that done. So we're on a pretty tight turnaround to get that done. So if you look over here, the last thing of the CHA, besides the MAP assessments that we need to have all done, is the identifying of strategic issues. So we'll kind of go through that in the next slide on what we need to do to get to that point. And then after we do that, the next 3 steering committee meetings will work on formulating goals and strategies and some initial action steps for the strategic issues that we decided to work on as a group. So that's kind of where we are and what we're trying to head to get down to December 31st and have that health improvement plan submitted to the state. So let's look really quickly at that, some of the planning milestones. So as I mentioned, we have 3 steering committee meetings that we are going to be working on. The final goal of getting strategic priorities together that we can then present to the Healthy St. Lucie Coalition meeting for their input, and hopefully we adopt those priorities at that November meeting on the 12th is the goal. So today we're going to look at the community health profile. We're going to look at some of the emerging themes and priority populations that came out of the community health assessment. At the next meeting, we'll look at some of the risk and contributing factors to health, and especially those top 5 causes of death and contributing factors to that. And then hopefully end by looking at the historic and current CHIP plans that we've been working on and how they've kind of evolved over the couple of years, just for that context, so that when we start thinking about where we want to head next with the CHIP, that context is there. So following the adoption of the priorities at the November Healthy St. Lucie meeting, the next 3 steering committee meetings will then start looking at the goals and objectives for those priorities, looking at evidence-based strategies, and we're going to send you links and documents of evidence-based strategies to look at prior to the meeting if you've got time. I know you're busy. And then looking at some initial action steps for those strategies. And then again, meeting at the Healthy St. Lucie meeting in December, presenting those goals and strategies and initial action steps, looking to see if they have any changes they'd like to make, and if not, hopefully we move forward and adopt those. And what will happen after that is our staff here at the health department will finalize the writing of the CHIP plan, which includes some narrative and framing in the front, along with the final plan in place with partners involved and things like that. So I know this sounds like a lot, and it really is, but I want to let you know that we have used our CHIP plan and pulled that out. We use action plans as well. We use it all the time to look at where we are. So this is not going to be a plan that's going to go on the shelf in our offices here, that we don't pull out and look at how we're doing on that. By the same token, we can change things after the first of the year. And I think it probably will, because we'll probably have some work groups and things like that that form out of what we're going to be working on, or that continue that we have now, that will then start fleshing out some of those action steps even more. So I think there'll be immediate changes to the CHIP plan that we submit based on how we start working on that plan. So I don't want you to have any fear that that we're in such a rush to get some of the stuff done that we don't have the ability to shape and change that plan after we submit it, because that would be silly. So I just wanted to give you all some of that background, how we're going to move forward. And then our goal is to get you materials you need prior to the meeting much sooner than you did yesterday. And then minutes from meetings in case you missed it, and recordings from meetings in case you missed a meeting, to keep you informed all along the way. So any questions or concerns or anything you think we need to change on this time frame, or things you think you might need that you don't have now? And if you don't have anything you want to say now, but you're keeping notes, you can always put those in the chat box too, okay? So to kind of start out today's meeting, Edgar Morales has put together a health profile for St. Lucie County that I think really gives us a good framework and a handle on what are the leading causes of death and some of the things we're facing in our community right now, before we start diving into some other pieces. So without further ado, I'd like to turn it over to Edgar. Edgar, are you there?
Okay, I'm here. Can you hear me?
There you are, we gotcha. Okay.
Okay, I touched that unmute button and it wouldn't go off. Okay.
Okay.
Well, welcome everyone. And my name is Edgar Morales. I work with Jennifer and Stephanie. It's a pleasure to be working with a great team that has the health of the county in mind. And I'm sure that all of you as partners of public health, you also have the health of the county in mind. So the purpose of this profile is just to give you a snapshot, just a very high level view of the health of the county, so that we can actually begin to tell the story, health story about the county. Together with all of the assessments that we have done so far, they all tell a story. And perhaps by looking at some numbers and some information, and having you provide a feedback to us on those numbers, figures, and statistics, and all that numerology, perhaps we can come up with a story, with something that it's more than anecdotal, but more into, yes, this area is of need. Yes, this area, in this area, we are making improvements in this other area, but we need to touch on this specific health group or community group, be it racial or ethnic. Maybe there are some areas where we have overlooked and we need to go back to. So I just want this to be a very interactive presentation. If you have something to say, You can always chat. I think there are some people that are going to be manning the chat room. And whatever you say, it's going to be very important, whatever feedback you provide. So please be vocal. So let's start with the first slide.
I'm sorry. There we go.
Okay, so the first slide or a series of slides are about the population of the county. As you see, St. Lucie County has passed the 300,000 mark. It's unbelievable that we've seen a boom of population coming in to our county. But the fact is that our county is growing older, and this is something we need to be mindful of. The median age in St. Lucie County is greater than the Florida median age. It is now at almost 45 years of age. And our county is growing older, while at the same time, our younger population is diminishing. And that could be several reasons. It could be that our younger population is moving into other metropolitan areas. They're moving because of education or because of job opportunities. So there are various reasons why this is playing out in our county. Let's move on to the next slide. I think we jumped one slide.
Sorry, we did. There you go.
There you go. Okay. All right. Thank you. At the same time, we need to look at some of the racial differences in our county. And as you can see, our county is well diverse. There's quite a diversity in St. Lucie County compared to the state. And as you can see here, the white population is about 74% compared to the black population, which is about 21%. If we move to the next slide, you're going to see something interesting that is playing out, and that is that our Hispanic population is now about to match the black population. So very soon, probably within the next year or two, these two groups in our community, the blacks and the Hispanics, are going to be forming a great portion of our population. So that's another thing we need to think about. So the takeaway about the population summary that I want to give you is this: our population is growing. We need to also know that Port St. Lucie as a city within our county is now the 7th greatest metropolitan area in the state of Florida. We need to keep that in mind. And that population is going to keep growing. The other thing is that our community is diverse. Our Hispanic population is going to match the population within the black population. So all of these demographics do play a great deal as a factor of health within our county. I don't know if you have any comments about this. Anyone who would like to chime in and provide an insight of the future of our county in terms of population and in terms of racial or ethnic differences. Is there anyone who wants to comment?
This is Nancy from Area
Yes, Nancy.
Agency. Hey,
Yeah.
Edgar, thank you. I'm wondering if you might want to add the 85 plus population to that first slide. Typically, that's the fastest growing segment of the population. I think that will have a lot to say also about health and wellness and how long people are living and what special needs that they may have.
Okay, we can do that. We can certainly look at the Census Bureau and the data sets that they have for 85 plus years of age. Yes, and that's a very good question. That's a very good point, because one of the tenets of Healthy St. Lucie is to have a population that is healthy, that has quality of life, and and there is a lifelong journey within centenarians. So that's a very good point, and I already wrote it down, and we can look into it. Any other comments? Yes, thank you for your comment. Any other insights? Okay,
Sheree,
we can move on.
Sheree,
Oh, there we go.
I'm sorry.
Within the Black population, we may want to look at the country of origin, or sorry, country of origin for linguistic and cultural differences. That's from Sheree.
Okay, so we can indicate origin, country of origin within the Black population. Okay. All right.
I'm just thinking. I was just thinking about like the outreach that you do to the Haitian population or Jamaican population may be different because there are different cultural and of course linguistic needs.
That's a good
Very
point.
good point.
Yeah.
Very good point. Yes. Any other comments?
Could you repeat that again, please? I didn't hear that. I'm sorry. This is Lorraine. Last comment, what she suggested.
I was just suggesting that as we start to look at interventions or ways to outreach, specifically looking at the Black population, I know that there's a large number of Jamaicans that live up in Port St. Lucie, a family that's up there. And then also there is a growing Haitian population as well. So, you know, the cultural differences there versus like the Black American population is different. And when we talk about healthy eating and, you know, different activities, there may be some cultural ways to connect with certain communities more. And then, you know, with Haitian communities as well, there's going to be that linguistic, you know, need to provide like, you know, resources in a different language.
I think that's a great point. And I think that that's definitely going to need to be teased out with every priority that we select. And then when we start diving into, so that's a priority, but which populations are priorities, and then making sure that it's all culturally relevant, the linguistics are there, and that we're taking, I think that's a great point. And I've got that noted too, Lorraine, if you didn't hear that we can make sure that gets put in there.
Excellent. I like it. The feedback is very important. And please understand that this profile is at a very high level because of the time constraints and the amount of time, you know, and space within this webcast we have. If there are no other comments, we can move on to the next slide.
Yeah, okay, there we go.
So we also need to talk about the socioeconomic factors within our population. And again, we don't have all of the pieces of data for socioeconomic factors, but these are probably the ones that we can look at right now and initiate a conversation around poverty health. The poverty level in our county is almost at the same level as Florida. The percentage of 25-year-olds with no high school diploma, that's always been a concern in our county for a very long time. I know that there have been many improvements in this area, but we still have room, a lot of room to grow in this area and to improve. Especially when we want to make sure that people are educated, especially the young people, especially the working population in our county. Those individuals who are in from 18 to 64, they also need to be educated and skilled in what they do. Also, we want to look at the percentage of adults with health insurance coverage. This is an area where we have done improvements. I remember about 10 years ago when our county had a population of 25% in the population did not have health insurance coverage. That has shrunk. We're narrowing the gap there, but we still have room to improve in that area. And then the unemployed civilian population, we're at 6.5% compared to Florida's 6.3%. And I'm going to stop now and listen to your comments. If you have any comments about this, please.
Edgar, we did have a question from Bridget on the previous, no, on this slide about the data from 2014 and 18. Oh, she said disregard. Hello, but also keep in mind the new thresholds will be beneficial. Yeah. And I think even within the slide that we're looking at right now, there's a lot of disparities in some of these areas as well. Yeah. And I think depending on where we go with some of the priorities, we definitely want to dive into the disparities in here. And whereas health insurance coverage, we've made some strides, we still, for that group that does not have it, we still have some major issues there that need to be resolved too. So do we know, another question coming out, Edgar, is do we know how many children have insurance?
We do have ability to pull that data, yes, yes. We can, because of the time constraints, again, I'm writing all this down, but we do have that data and we can answer that next time we have our meeting. But definitely there is data that we can pull from the Census Bureau on who has health insurance, who has not.
Hi, this is Sherry with the Treasure Coast Food Bank. I don't know the exact number, being with Florida Kid Care with the children's health insurance, but I know St. Lucie County, we are above most counties where children are concerned, with the number of children we have enrolled in health insurance percentage-wise. So we have made a lot of strides in that. And if you guys do have families who are in need, please send them my way.
Okay.
And what is your name?
It's
Sherry Reed with the Treasure Coast Food Bank. And I'm also the current chair of the Treasure Coast Florida Kid Care Coalition.
Excellent, thank you. Again, yes, I just want to say that, again, for any of these data points that we're showing you, we can definitely look at the health disparities within racial lines and also ethnicity lines. So yes, we can always break down these pieces of information. Any other comments? Okay, no more comments. Let's move on to the next slide, please. Okay, now look, we're going to move into the area of health outcomes. And one of the things that we always look in communities are the leading causes of death in any community. This is one of those public health tenets that we always do in epidemiology or in disease control. And what you see here in this slide are the 5 major leading causes of death in St. Lucie County as of 2019. Every year this list comes out. The list is really long. It's probably about 25 different causes of death, but these 5 comprise 66% of all deaths in St. Lucie County. They all now, before I jump into years of potential life lost, I want to say that cancer and heart disease comprise of almost 50% of all deaths in St. Lucie County in 2019. I just want you to keep that in the back of your mind. Cancer and heart disease actually came up as together. They comprise 47% of all deaths in St. Lucie County. That's a staggering number, especially knowing that there were about a little over 3,000 deaths in St. Lucie County in 2019. There were about 1,600 over 1,600 deaths between cancer and heart disease. Now, years of potential life lost. This is a number that we always look in public health, and it's a very important number. So these 5 categories of leading causes of death, they actually all put together come up as, they actually comprise 62% of all the years of potential life lost for people who died before the age of 75. Now, what is years of potential life lost? It's actually a number, it's an index, it's a number that is, it's the difference between the endpoint age, which in this fact is 75 years of age. So it's the difference between 75 and the time or the age of death. So when you look at the difference between those years, those were years of life that were lost before the age of 75, and all of that number is put all together in a population. So you can almost think about all the thousands of years that are lost when you count all the lives that were lost before people reach the age of 75. So that's why I bring this up, because that's why it's important to look at the leading causes of death, because they provide a sense of the burden of disease, the burden of disease within a community, and how that affects how that can affect the economy, the quality of life in a county, and the health of the county overall. I just want to stop here, and if anyone has a question about this, please, you have time to ask now.
Edgar, I just want to make sure I understand, Jennifer. The 66% of all deaths, that's from all the top 5 causes, is that correct?
Yes, all the top 5, yes.
Okay.
But
I think I
cancer
moved
and
your bullet today, and I think that made it a little more confusing. It's not all related to unintentional injury, so I apologize for that.
That is correct. That is correct, yes.
Okay. If anybody's interested in following along in the profile handout that was there, Edgar is working on page 6 at this point, and that shows the page 6 in there shows the rates of death. And at some point, I'd love to be able to see those based on percentages, because I know that's where you got this more than 50% is the first 2 combined. It's hard to look at that and calculate it based on the chart. So.
Yeah. No. Again, all combined, all of these 5 leading causes of death combined account for 66% of all deaths in St. Lucie County. That's according to the figures that I was able to count, that's over 1,600 people who died from cancer and heart disease, all combined. Any other questions or comments or insights?
It's Nancy again. I'm just wondering, can we get a breakdown maybe of the unintentional injuries? I think that the Department of Health has that. I know for seniors, falls is a very big thing, and I saw something about other ages for poisoning, and that will let us know later on where is it we should be directing our attention to prevent those.
Definitely, yes. That's a very good point. Unintentional injuries, the 3 major unintentional injuries are motor vehicle accidents, poisonings, and falls. So we can definitely break this down into those 3 categories, and we can also break it down by race or ethnicity.
And age probably too, right?
And also age. Yes, we can break it down by age. Absolutely, yes. Thank you for your comment.
Very good, thank you.
Any others? Okay, we can move on then to the next slide. The next series of slides are going to give you a little bit more sense of each one of these leading causes of death. And again, this is looking at a very high level, very high level.
One last question, sorry. I wanted to finish off the top. Cherie's asking if diabetes was in the top 10, to your recollection.
Let's see, let me,
Is that in the
I can look at this if you give me just a quick moment, I can look it up.
I've actually got it in front of me, Edgar. It's yes.
The answer is yes?
Okay, good. Thank you, Steph.
Yep.
Okay, thank you. Yeah, the answer is yes. Within the top 10, we also have Alzheimer's disease, septicemia, chronic liver disease and cirrhosis, hypertension. So those are the top 10. But again, because of the numbers and the huge numbers and looking at the very high level, we look at the first 5, the top 5, because you will find that some of the risk factors that play within these 5 causes do also play out in other causes of death, such as diabetes and hypertension. So if we look at the top 5 and we look especially cancer and heart disease, some of the risk factors within these 2 areas or classes of death will also, if we address them, will also touch and impact other diseases. All right, if I can move on then, and please, if you have another question like that, please stop me and we can entertain your question or comment. So here you see cancer. Yes.
I just want to let everybody know, because there was the question about the children's health insurance. I put the link to the latest enrollment data in the chat.
Oh, thank you.
Awesome, thank you.
Thank you very much. So here we have cancer as the #1 cause of leading cause of death in St. Lucie County in 2019. And what you see here are 4 panels. Basically, the 4 pie charts that you see here are age-adjusted death rates. And whenever you hear me talk about death rates, it's always age-adjusted, which is a way of weighting, putting a weight on every death for every age-specific death, so that the death rate is not lopsided or skewed towards a specific age group. Okay, so it actually helps us look at the death rate within the community, and we can compare it with the standard population or with the rest of the population. So anyway, it's a very important aspect of looking at death. So here you have cancer, and what I can summarize here is that pretty much cancer affects both sexes. It also affects every race, and one thing we can see here is that in one of these pie charts is that it affects more the non-Hispanic population rather than the Hispanic population. Now, why is that? Could it be that the Hispanic population has needs more access to health care or access to cancer services? We don't know. That would be something that we need to look into. But that's the numbers do not reflect what is behind, what is causing these numbers. So that's why we have to dig in by utilizing the other assessments that we have pulled together so far. And you can see the years of potential life lost there on that histogram or the bar chart. And like I said, the non-Hispanic population has the most years of potential life lost out of these groups. Any comments about this slide or any comments about cancer at all in general? All right, if no comments, we can move on to the next slide. Then we have heart disease. Here with heart disease affects males for the most part. It's equally distributed among races. It also affects the non-Hispanic population more than the Hispanic population. And you can see the years of potential life lost before the age of 75, how that breaks down. Okay, any questions about heart disease?
Or comments or?
Yes, insights.
Insight, data.
Requests.
I was wondering about the diabetes rate because I know that there's a huge link between type 2 diabetes and heart disease, or the incidence of heart disease in adults. People with type 2 diabetes are at a 2 times risk of dying of heart disease. So I'm just thinking that there may, like, I don't know if there's something that you could, if there's a way to drill down to see if, like, of those deaths who had multiple, like, metabolic syndrome issues, and, you know, just also going back to, like, interventions, the a lot of the behavioral modifications that would lower somebody's risk of dying from heart disease are also going to impact diabetes, and I mean may impact, you know, cancer as well. I'm not too familiar with cancer and the behaviors related, but, you know, just thinking along those lines.
No, that's great.
Excellent comment. Yeah, diabetes is definitely a comorbidity of heart disease. They usually go hand in hand. Usually, and you know, this has happened in my own family, in my own experience, where a death in the family is recorded because the individual died of heart disease or a heart attack. The individual had a heart attack, but that same individual had years and years of diabetic or metabolic syndrome, and had diabetes for a long time, for, you know, 5-10 years. But usually in the death rate, in the death certificate, the main cause of death usually is written as ischemic or a heart attack. So that's a very good point. Any other comments? All right, if no more comments, let's move on to the next, stroke. So here with stroke, well, you know, it's equally distributed among males and females, basically. It does affect the Black population more so than other races, and perhaps this could be something we need to look into, why that is. Could it be access to healthcare issues? Could it be that we need more specialized doctors in the area that can treat stroke? Or I don't know. I cannot draw a conclusion by just looking at numbers, but this is something we need to look into. It also affects the non-Hispanic population as well. That again, I find this very an interesting aspect in terms of the stroke and how it affects Blacks who died of a stroke. Any insight on this? And perhaps stroke could probably be linked to, again, heart disease, and it could also be linked to someone who is suffering from diabetes and suffered a stroke or died of a stroke. It could also be a comorbidity for other issues.
Sonia wrote in the chat box if we have a breakdown of stroke by age. I don't know that we have one right now, but we definitely can pull that down, right?
Yes, I believe we can. Yes, we can break it down by age. Any other comments?
I don't mean to keep tapping into Cherie, but this is kind of her background.
I'm like, I don't know if I should comment again, but when it comes to stroke, some of the stuff we've looked into has to do with like a lot of people when it comes to a heart attack, like they think somebody like grabbing their chest, oh my gosh, they're having a heart attack, let's call 911. But with a stroke and with heart attacks, a lot of times like those heart attacks or strokes that put people into the hospital, they'll realize that there were a number of mini heart attacks prior to that, or a number of mini strokes, or TIAs, transient ischemic strokes. I'm not a physician, I just kind of know a little bit about this stuff, but there were a number of those that happened prior. And so we've tried to get the word out there about what to look for when it comes to a stroke, and, you know, the face drooping, you know, not being able to like move their hands and, you know, their limbs, and not being able to speak, all of those different things, you know, so that people, when they see that happening, they'll know that it's a stroke and call 911. And then also one thing that we've seen is in communities of color, you know, sometimes it goes back to that mistrust of like police and not wanting to even call them. And so thinking that, you know, if somebody is having a heart attack, it's kind of like different. They're gripping their chest, and even, you know, even then you sometimes don't see it. But I think that some people may not realize those signs and symptoms of a stroke and what actually happens, and like they just don't understand it.
Okay,
Yes, thank you for your comment. So what I hear you say is that there's an opportunity here to educate, inform and educate the population around the signs of stroke, what they are, and what to do if you have X, Y, and Z symptoms.
Yeah, and then you know, then it goes into like the clinical system and stroke care. I don't know too much about like the hospital systems there and the like stroke centers that are located in St. Lucie County, but there may be like some conversations that need to be had around the stroke centers and the quality of the stroke centers. We have like different trainings and stuff for those. Like we have a whole quality systems improvement department that's separate from the work that we do in the communities that help with like improvements in the hospital systems to make sure that like stroke care is timely and is given, you know, at the best quality. So that may be an intervention as well, and I could connect you guys with those people if there's a need.
Oh yeah, great.
That's an excellent point. Excellent point. Any other insights or comments, questions, suggestions?
Stephanie's just added the stroke adjusted age adjusted from Florida charts in the viewer too, if anybody wants to take that out, cut and paste that into your browser to look at too. But I'm sure as we pull into some of these more, we're taking notes, we will try to look at those again. And there's going to be another opportunity to revisit these on our next call. So you're helping guide where you want to see more information and some breakdowns, which is really helpful.
Yes, definitely. Okay, I guess we can move on to the next slide.
Okay.
And again, if you have questions about the previous areas or leading causes of death, you can always chime in, please. The next one is about the chronic lower respiratory diseases. And, you know, these are the diseases of the lungs, basically, the lower part of the lungs. And that includes asthma, emphysema, and there's a whole family of lung diseases that fall into this category. And what we see in the data is that females are more affected than males. Whites are more affected than any other racial group. And then we see the non-Hispanic group greatly affected in this area. I would like to entertain any comments. I don't know if anyone is an expert in the group about pulmonary diseases, or if you have any other question or concern. No comments? Okay, very well. We can move on. Again, some of these, we're going to see perhaps that some of the risk factors of these diseases, especially the chronic lower respiratory disease, may be linked to heart disease and cancer, or maybe some other ones. So you know, we're gonna have to drill this one down, why these specific groups are affected more in this area of leading cause of death. All right, now we move on to the unintentional injuries. Here we see that males are greatly impacted with unintentional injuries. Males, whites, and non-whites. I mean, non-Hispanic. Males, whites, and non-Hispanic. And again, the three major unintentional injuries in this category are motor vehicle crashes, poisonings, and falls. So I know that I know there was a comment earlier about breaking these down a little bit more into age groups and perhaps into the different. Yes, basically, I think it was the request was around age groups, and we can definitely do that. But is there any other comment around unintentional injuries, or around any of the top leading causes of death?
We got a question from Sonia about whether, and I'm assuming she's talking about the previous slide on chronic lower respiratory diseases, correlation with this and with environment and or smoking. She said yes. Yeah, and I'm sure. And Edgar, we could probably look at some of the contributing factors, and that's the whole call next week's going to look at contributing factors to some of this. So I'm sure we're going to see environmental factors, smoking risk factors, and we've got Stephanie on today, but I don't know that she's ready to address, but we do have some we've got tobacco advertising, tobacco companies, there's all kinds of different factors in here with some of this. So we will try to look at, I see, okay. And now another question with unintentional injuries from Nancy in the chat box. I think it'd help to break down by cause of injury. And you did say motor vehicle poisoning and falls, but we might want to take a broader look at some of those pieces and age groups and stuff like that. So, okay.
Absolutely. Yep. Yeah, we do have the ability to break this down a little further. So absolutely, those are good comments. Okay, all right. If there are no more comments on unintentional injuries or any of the other leading causes of death, we can move on to the next sector of health. We can move on to the next slide.
I'm sorry, I was reading the chat box, sorry.
No, that's okay, that's okay. We have time. Okay. Yes. Now we move into the infectious diseases. And again, this is just a summary, a very high level from the profile about the years 2000, between 2017 and 2019. This is a 3-year trend, is that we still need more work to do with sexually transmitted diseases, especially syphilis, chlamydia, and gonorrhea. In the area of vaccine preventable diseases, we need to work with our population in getting vaccinated against hepatitis B. We've done great strides in HIV/AIDS and tuberculosis, but we still need more work to do in the areas in the high-risk communities. And some of the high-risk communities for HIV/AIDS and TB have been identified as men who have sex with men, also the Black population and the Hispanic population. Those are typically right now statewide and also within our county and also within the area. Those are the three high-risk communities that where we have a plan for preventing HIV/AIDS and tuberculosis. Then we have foodborne and waterborne diseases, and the top two are Salmonella and Campylobacteriosis and Salmonellosis. These are diseases of the food. Basically, it's meat or meats that have not been cooked well, and or people are contracting these illnesses through either poultry, seafood, they've been in contact with pet animals, or they have been drinking untreated water. These two are whenever you look into any community, any county within Florida, these two always come at the top. So there's got to be perhaps a little bit more education in the population on how to cook the meats, what are the right temperatures to maintain clean food for their table, and so on. And then finally, we all know about the pandemic. COVID-19 is with us, and we don't know how much longer it will be with us. But this is an area where we need to always think about, not only in the present, but also for the future. And I'm going to stop now and entertain some comments, insights, requests, questions.
Edgar, we did have one in the chat box asking about Hep A, that it was a big issue last year. Where are we this year with that, and is it still a big issue that we should be looking at?
Because of the great work of vaccinating people for Hep A is not really now in our radar screen. No, now, that I'm not saying publicly here that people should not be vaccinated against Hep A. They should. But because of the outbreak last year in our area, there was a great effort in vaccinating people, and that actually is paying off today for 2020. So, but Hep B is in our radar screen, and we need to inform people to be vaccinated against Hep B. So those two go hand in hand. Hep A's and Hep B, hepatitis B, people need to be vaccinated against both of them. But I'm just making one emphasis here with hepatitis B.
I will also tell you, Edgar, that some of the things that I've read, this is Stephanie, that the increased hygiene and hand washing related to COVID has also greatly contributed to the decline in hepatitis A.
Yes, that is correct. That's an excellent insight there, which again, we need to educate the population, continue to educate the population with these basic public health measures that are easy to do, but we always forget to do them, especially washing our hands. Any other questions or insights? All right, so let's move on to the next group. of health outcomes, and that is in the area of maternal and child health, teenage pregnancies. I know that we have done a great work around preventing teenage pregnancy, but again, we still have more room for improving in this area. And I think Sonia can speak a little bit about this, but it's not just teenage pregnancy with this age group of 15 to 19-year-olds, but it's also about this same age group for repeat teenage pregnancy, where we need to continue to educate our young people, especially with their reproductive health, educate them about not only abstinence, but also contraception and ways to avoid becoming pregnant while they are young. And so we need to continue to educate. And I'm going to stop here and allow Sonia to speak if she wants to.
Sure. So I just want to make a couple of comments, and I put it in the chat box as well. We need to look at collectively how we can better improve client engagement into our existing programs. And I'm specifically referring to maternal child health because that's my scope of practice. But we have programs available. We have lots of services available to address improving teen pregnancy rates. How do we, addressing infant mortality rates? But those don't work unless we get the clients to participate, unless we get them to agree to, unless we get them to understand the benefit too. So there is some discussion I think that we as a community collectively have to have around that topic. Second, when it comes to teen pregnancy, yes, everything that Edgar said is correct, but we also need to unwrap that further. A lot of the teens that we work with come with a lot of trauma, a lot of baggage, and that's not something that one program can do all by itself. And so when we look at teen pregnancy, we also have to look at their childhood trauma and other mental health issues, and how can we kind of fold all of that together, because it's like unwrapping peeling the layers of an onion. Yes, we can address their education needs and reproductive health services. Yes, we can get them tested. Yes, we can get them on birth control if they want to, but that doesn't address the deep-seated underlying issue as to why they continue in some of these high-risk behaviors.
So it almost sounds like, yeah, it's a big point. I see Dorothy in the chat box said yes to that. It almost sounds like we need to be a little bit more generalist in our approach, and not generalist to like we don't know enough, but we need to be more comprehensive around what we do and more knowledgeable on some of these pieces, and how do we link or be able to treat at the same time at is that what you're thinking, like one stop or broader ability, Sonia?
Broader, I think. Broader.
Or maybe you don't have the answer right now, you just know it's a gap.
It is a gap. You're right. It's a gap. I'm not sure how to specifically address it right at this moment. It's definitely a gap when we're talking with teens, when we're talking with young families, and we're talking with moms. There's a gap. And, we've had some listening sessions regarding infant mortality, and you kind of hear that same gap. So there's a gap between between the existing services that we have for pregnant moms and teens and getting them to engage in those services. There's a missing link there.
Okay.
It's the discussion with those kids as they're coming into that age. It's the education of what the health risks are, not just teen pregnancy prevention, but but the impact that it can have on their whole life, on their health, on their economics. It's it's an educational need that needs to be addressed, and a big part of it, I think, needs more time, more cooperation, more support through the public school system. It's got to be a community-wide effort, not only the healthcare population of providers in the community, but educational providers.
Agreed.
Great point, Jim. One of the things that the Economic Sufficiency Network under the roundtable is looking at is what are the causal factors for disconnectedness for youth who are 16 to 24, because it does have huge impacts. And one of those greatest impacts was teen pregnancy. But as we've been teasing out these factors, it is so complex to get upstream from this to start looking at those pieces. It's going to be a while as we look at how we're going to impact those individual pieces. And we've done, from our data, we've done great things through teen pregnancy prevention. I think, I'm not sure what those numbers actually look like, but we're still seeing high disconnectedness due to trauma.
Yes.
I will tell you the literature right now is projecting that we are going to see increasing numbers of disconnectedness of this use because of the COVID virus and getting kids to be going virtually to school. That level of engagement is just not there right now for what, you know, when you're talking about somebody who has all these complex trauma and community challenges to, you know, even if you don't have access to Wi-Fi, that can have an impact on a youth's ability to stay connected. So I think this is definitely something on the upstream side that's going to require a lot of analysis and trying to identify where we're going to get our greatest bang for the buck, so to speak.
Great points. Jim and Stephanie, you should be preachers because that is awesome.
Yes, I'm done.
Nancy, what'd you say?
No, I'm saying that Jim and Stephanie, you should go on a preaching circle.
No, somebody else was trying to say something. I thought it was Nancy.
Oh, yes.
Not me.
Any other comments?
If I could just chime in on the sudden infant death.
Oh, yes. Go ahead. Go ahead.
Been working a lot to educate the community on infant safe sleep. And I just want to make a quick note here that last year in 2019, there were, I believe, 9 infants that died, and that the medical examiner had done autopsies on. 8 of them came back with a cause of death related to unsafe infant sleep. So it was related to co-sleeping, positional, suffocation, something related to the infant sleep. So last year that was a significant issue. And this year to date, there have only been 2, and one of the two infant deaths has been related to sudden infant death or to SUIDs, which is the newer term.
Yes.
So there's been a lot of work around that topic by many of the different maternal child health programs, particularly within the health department and Healthy Start.
Great.
Yes, and I personally sit at the table with the group of people that Sonia has put together for case reviews. And it's an awesome group. A lot of good discussions come out of that group and great recommendations. So yeah, this is an area where we need to continue to tackle. And incidentally, I put these 2 pictures there for a purpose. The picture that you see on the top right, that's a very cute picture, isn't it? But it's the but you see the child sleeping, you know, that is only cute for pictures, only for picture taking, but it's not for sleeping, because you see the kid wearing a little cap. Then the blanket is all fluffy, and it's not the type of blanket or sheet bed sheet that you would use for a child. and the position of the baby is in the wrong position. And then at the bottom center, you see the right way of allowing a child to sleep. He's on his back or she's on her back. The 1C is one single item. On that bed sheet is just the child. It's only the child and only the child. I don't know if you have any comments about that, but it's important that we need to educate the future mothers on how to allow their babies to sleep.
And not just mothers, any caregiver.
Any caregiver, yes. We need to also educate the grandmothers, because there is a sector in our population that is actually taking care of babies, and these are grandmothers taking care of babies, especially if the mother or the father have died of whatever cause, and now they're taking care of a baby. And you know how grandmothers are. They think they know better, and they do. They think they have a wealth of knowledge, but when it comes to raising a child, or not raising a child, but actually putting a baby to sleep, and that's where we get a lot of pushbacks. Am I right about this, Sonia?
Extended family, grandmothers, aunts, they're very influential in child rearing practices. And it's a big barrier when it comes to having, education about safe sleep. And so we do have to keep that in mind, that we don't want to exclude them. They are a very, very influential member of that household, of that family.
Okay, now let's talk a little bit about low birth weight. That's another area of risk for infant mortality. And of course, this is another battle that we're waging. It's those females who come late or do not receive prenatal care for whatever reason, either because they have lack of access to health care, or they need education, or they do not have a doctor, or the doctor is now residing in a different county and they don't have the transportation to go to that county. There are many factors that play around the area of prenatal care, of not receiving prenatal care or going late into prenatal care. Sonia, you want to chime in?
So the data has improved actually on entry into first trimester care. And I really want to, I hope that it's related to the fact that we now have outreach workers available to literally go out into the streets, out into the neighborhoods, and locate women who are pregnant and get them into our system of care. And that's not just OB care. That's also making sure that she's got her pregnancy Medicaid, that she's got WIC, that she's in our home visiting programs, that there's transportation issues identified, that she knows how to make appointments. It's one thing to say, here's Dr. So-and-so's number, give him a call. It's quite another to say, let me help you make that appointment. Is really just coming alongside some of these high-risk moms and walking them through, kind of being like a peer navigator almost, to navigate them through the prenatal care system. And so those numbers for early entry into care have improved since 2018, I believe, 2017, 2018. So that's good to know. We did initiate a doula program a year ago, and the numbers are low, but the outcomes are showing to be very favorable. And for those of you that don't know, a doula is a labor support coach who provides continuous labor support. And we directly are targeting those efforts to our high-risk neighborhoods. And 100% of those babies so far have not had low birth weights because they had continuous support. Now, is that the only reason? No, but it sure helps.
That's definitely a contributing factor to the improvement.
Definitely.
Well, thank you, Sonia, for your insight. That's very important.
My pleasure.
And it's we're glad that things are improving in that area. Okay, let's move on to the next section of health. The next section of health has to do with behavioral risk factors. I just want to give you a little background here. The behavioral risk factors in the profile is basically a survey that is done in our community every 3 years, and this is run by the state. And that survey, it's a scientifically formatted survey that makes phone calls at random. They make phone calls at random in our community. And if I can recall, the 2018 behavioral risk factor survey actually surveyed about 512 of our residents. And again, they were picked at random. The survey is done scientifically. So from that survey, the areas that we see of greatest concern are the heavy or binge drinking, cancer screenings. What that means is that people are not getting their cancer screening appointments that they were when they turn 50, for example, for colonoscopy. Now, in the area of mammograms, we're doing much better today in the area of mammograms. Women are getting their mammograms in our county. Is there room for improvement? Again, we're going to have to look at the health disparities or health inequities along racial lines. And then with prostate cancer, we do see the need to educate our men more in getting their prostate cancer screenings. This type of screening is now done outpatiently, and it's through a little bit of a blood draw. So it's very simple. You know, now that I'm over 50, I have to do this, you know, every so often, you know, according to the doctor. The doctor will remind me when to do it. So there's a little bit of education in terms of cancer screening that we need to do in our population. We need to do a little bit more education. And then healthcare access and insurance coverage. Again, this area, we need to look at the health inequities along racial lines and ethnicity. And then finally, immunizations. We need to continue to educate the entire population, especially because of COVID-19. We need to educate people to get vaccinated against the flu, and also for people who are above age 60, they need to be vaccinated against pneumonia. Any comments about the behavioral factors that we present here? Any comments, insights, or questions? Again, these are highlights.
Sorry, go ahead.
Yes, yes. What's your question? No comments or questions? All right, we can move on to the second slide on behavioral risk factors. And I know that, you know, with Healthy St. Lucie, we have started a great deal of work around people getting to be more physically active and be mindful of what they eat. But we need to continue to make improvements and educate people on avoiding to becoming overweight and losing weight and becoming more physically active, and to quit smoking. Quit smoking is still the #1 preventable behavioral risk factor that actually prevents many illnesses, especially cancer, heart disease, and stroke, and many, many others. And so, you know, it also it makes an impact on the chronic lower respiratory diseases in our county. So any comments whatsoever about risk, these risk factors, behavioral risk factors? Okay, if I don't hear any comments or insights, we can move on to the next area. And I know this area, this is a big area for our county. Social and mental health. And I know some of you have already made some comments about the need to know how teenagers are impacted, especially with social distancing and not being able to see their friends. There is a big deal of concern around the area of suicides, depression among the youth, but also there's depression among adults. Let's not forget about the adults. And I put this picture about Anthony Bourdain. You know, I know that we were all shocked about the news when he committed suicide. And you know, here's this well-known man with a great show on television that made a great impact on many, many lives. And yet, you know, we lost him through suicide. So the need for social and mental health in this county is really, really important, especially when it comes to crime, preventing crime and violence. So I just want to entertain any comments and insights or questions in this area.
So Edgar, I think we did talk about how the crime and violence has gone down, but there's still a lot of work to do. Suicide has gone up, and then hospitalizations for mental health have gone up as well.
That is correct.
Okay.
That is correct. We are making impact in that area, but we still have a lot of ways to go, because when we compare ourselves, our county, with the rest of the county, I mean, with the rest of the state, that is, we still have a lot of room to improve in that area. We're not there, we're not at the target where we should be. Have we made improvements? Yes, definitely. Port St. Lucie has been on the news as being one of the safest cities in the country. But we cannot let up. We need to continue to stop the violence, and we need to continue to also stop the violence against ourselves. And that's why suicide and mental health is important in this county. We need to look into this area so that we can provide services to our youth and to our adults. Any other comments?
I would just say that when you talk about the social and mental health and the behavioral issues, as I think that a lot of times we don't tie the two together and then connect them back to chronic illnesses, and realizing how, you know, the ACEs and mental health can be triggers for some of those behavioral issues, and how they tie back to chronic disease. So if there was a way to make that connection, I think that, you know, it may help with you know, people. People just need to know that connection.
That's a great comment, because
I completely agree.
The numbers do not show the story. We need to drill this down and know exactly what is it from the community that suffers from social and mental health. We need to know from them what are the factors that are there. Yes. Any other comments?
We've got some comments on needing to focus on ACEs with children. That's where a lot of it begins. So in terms of maybe preventing those chronic diseases down the road by dealing with the trauma early on and focusing on that. So screen, educate, and prevent trauma. Yeah, and I think I'm not sure how we can tease out this stuff, but there definitely is a huge link between trauma and, ooh, I love it, trauma-informed yoga classes. Dorothy says yes. Yeah, I think that's definitely it's like Maslow's hierarchy of needs. If you're dealing with all that trauma or you've got so much poverty, there's no way to think about other things and to attain other pieces and items. So I think mental health is there too. If you're struggling there, then whether you eat a cheeseburger or a salad is not high on your priority list. So I do think that's a huge, impediment to health, and then long term you're developing chronic diseases. So that's a great point. So, and we're going to show a couple of slides here, some of the emerging themes, and I know that social and mental health came out through some of the surveys and the qualitative work that we did in the community health assessment earlier on this year, and this was echoed over and over again. Sonia, we'll miss you. Thanks for being here today. I see she's leaving. Dorothy says screening is important. So, I think if mental health and social, and then this ends up, we're going to need to really dive into what needs to happen. So that's where you need to leverage everybody's expertise on this and how to move forward if we add some new things into the CHIP plan that we need to really flesh out. So I love that. Love it.
All right, let's move on to the next slide, because perhaps the next slide can explain some things. I know this is a busy slide. It's a table that presents the health, the major health resources we have in our area when it comes to medicine and healthcare. But when you look at St. Lucie County against some of our peer counties that where we have sort of like the same number of or population base, if you will, around Lake County, Marion, Osceola, and St. Johns County. These counties are the closest counties to our county in terms of population. When you look at the resources these other counties have compared to ours, we have a long ways to go in terms of bringing in professional medical resource to our area, to our community. St. Johns County is right now well known as the healthiest county in Florida. But when you look at the resources they have, you can see why. You can almost see why they are known as the healthiest county in Florida. Look at all the resources they have. It's amazing. The rate per 100,000, the rate of providers that they have for every 100,000 people in their population is amazing. And then you can look at Marion County as well. Marion County is, yes, again, these rates are per 100,000 people. These are the closest peer counties to us in terms of population. But when you rate our resources by for every 100,000 people, we have some work to do right in this area. Now, I don't have the answers on how to bring to our county more dentists, more physicians, more family practitioners, or OBGYNs or pediatricians. I don't have the answer to that. How do we do that? But it is clear to me that part of the problem is that when we compare ourselves with other counties and their health, we do need resources in the medical professional in our county. I would like to entertain some insights on this.
Edgar, we did have a question about what about mental health providers?
Yes, I did not have readily available to me any information about mental health, but I'm going to be, it's in my notes to look into because I knew this question would come up, but I have to do a little bit of research on this area.
So we've taken that down. It's definitely a note. It was not on charts, so we are looking for a couple other resources for that to kind of, because obviously we all know that there's some issues with those providers and having enough. And I think we were low at one point with child psychiatrists. I'm not sure where we are with that right now. So we will definitely look into those numbers.
But if you look at this table, and if we utilize these practitioners in our county, the number of practitioners in our county as a proxy for how many mental health professionals we have in our county, you could probably guess that we don't have that many. Yeah. So I don't know. If you want to push me back on this, that's fine. I would like to entertain comments or insights or any suggestions, any recommendations, or if you do not agree, that's fine.
We also have something from Nancy. You might have to clarify for me. It's maybe CNAs. I know that Florida has a low number of them, but they're necessary for seniors who want to be able to remain in their home as they age. It's a really good point. So you mean maybe look into the number of CNAs per population here in Florida and St. Lucie?
Yeah, I know I have some data for Florida itself, and I know in Palm Beach County, one of the funders, that's what they're doing, is try to train more CNAs. I can get the source I have for Florida, and I don't know if it breaks it down by county.
Okay, perfect.
Just assistance with activities of daily living and independent activities of daily living.
Okay, perfect.
Any other comments either in the chat room or you can unmute your phone. Okay, very well. Jennifer, I don't know if we want to go back to, if you have any questions, if anyone has any comments, questions related to any of the pieces of information or presentations that we have made.
We did get a, sorry. Oh, go ahead, Nancy, sorry.
I was just hoping we could get data, and I have it by county, of Alzheimer's disease. I know you said it was like 10 or among the top 10 in terms of causes of death, but I know for the state health improvement plan and Governor DeSantis, you know, dementia and being able to address that is very important. So I was hoping maybe we could get those numbers in too.
Thank you. Okay, if no more questions, yeah, go ahead.
Sorry. Kathy was wondering if we could get the hospital's help in the recruitment of providers to the area. You know, it's funny, Kathy and I were kind of talking about that like yesterday, and like what's going to be needed, you know, what are the most common barriers and challenges in the community, and then how are we putting in a plan in place, or maybe there already is one, but I'm not aware of one, on what to do about recruiting more providers. That's a really good point. And then Patricia had that there are many ARNPs that are practicing with physicians. So that's an interesting concept. Like, do we have better coverage than maybe it shows on the paper? I don't know if that's where you were going, Patricia, but that maybe while we're down on physicians, we do have ARNPs that are able to see patients as well. Is that where you were? I'm not sure if that's where you were going. You can put it in the chat box or chime in.
So Jennifer, this is Angela. So in regards to physician recruitment, I know that internally at the hospital, we have certain service lines that they're working on recruitment for. But from this group, based on your findings, if there are certain areas that we think we should be hiring more positions, that those are service lines we have available, then we could certainly look into that, and I can provide recommendations. I know something that's challenging, we talked about, or Edgar spoke about mental health. And in Indian River, at Cleveland Clinic Indian River, we have a behavioral health unit. But here on the Treasure Coast, we do not have that as one of our service lines, so we don't have any employed positions that are psychiatrists or practicing in that area. So there are some barriers still in regards to that, but I'm happy to bring back anything you guys have.
Awesome, thank you.
You're welcome.
I mean, I'm sure the solution to bringing physicians here is broader than just hospitals, and probably needs city and county and all kinds of officials involved, and economic resource development. I mean, a bunch of players at the table kind of looking at that. So hopefully this plan and looking at some of this will just kind of start in a direction of conversation for that. So, but thank you for that. That's nice to know. Okay. So
Jennifer,
2000. Oh, go ahead. Sorry.
no, Jennifer, I don't have any more comments. So if you want to move on, that's okay.
Okay. And Stephanie, you just put the mental health data from CDC and state profiles for that there.
Correct. And I just found too that County Health Rankings has mental health providers listed under access to care. I haven't gotten into the data yet, but I'll take a peek.
Okay. So we'll make sure to follow up on that on the next call as well. Okay, and if you have any other data pieces that are lingering in your head and you don't, you want to get a hold, you can either email me, or if you want to email Edgar as well, or CC both of us on that, we would appreciate that, and we'll try to keep bringing that data back out and giving you copies of that and links to that for conversation. I see Stephanie's put some stuff in the chat box too for further information, so we'll make sure we pull that in and we're looking at that. Okay. So at our June 11th, thank you so much, Edgar. I'm going to move on like you told me to. So moving into the emerging themes. So in June, we had the consultants that worked with us on our community health assessment and doing a lot of the qualitative focus groups and stakeholder interviews that we did, the community leader survey, the resident survey. They put together from all of the surveys that you see here across the screen, found some emerging themes that came out of there. And they did present that on the June 11th, 2020, but I wasn't sure that everybody that's on the call today would have seen that list before. But I mean, you can see just from some of the things we're talking today, mental health came out, insurance came out of that too, and having coverage, housing issues, and I think that was around having affordable housing in the area, having a living wage and jobs and employment. Substance abuse came out, physical health with having access to specialists. We probably need a little bit more analysis on that from our conversation today, and adding the mental health pieces in for that. Nutrition and having access to food, the neighborhood environment, transportation came up across the board with that too. And then more prevention services, education, screenings, early interventions came up as well. And I don't know if you all have any more things you were thinking about, but I did want to kind of bring you back to where those came out with some of the emerging themes. And then also priority populations and geographic areas that came out were older adults, working with children and youth, working with the disadvantaged, low income, underemployment, underinsured. People of color came out as an issue that we needed to keep focusing on, and looking at some of the disparities that we have and some of the data we looked at today, that definitely backs that up. North Fort Pierce came up frequently as an area to focus on, and then there were some rural areas inner city and local, lower socioeconomic areas to kind of focus on. So you can see all the data that we have up here too, and we do have that local public health system assessment survey that still, we have not looked at that. So what we're going to do is look through the data when we start pulling that report together and looking to see if there's any new themes that come out of there, or if it's just echoing what we see here, to see if there's something new. I'm sure, you know, it'll be interesting just to see that, and we're hoping to have that for you next week as well to look at. If not next week, by the very last meeting, to help us figure out if there's anything else we need to look at. But we definitely want to see if there's something in there that we want some focus on as well. So any conversation on those emerging themes? I mean, I don't know if there's anything of shock to you or something you think was missed that we didn't capture or that wasn't captured in the data surveys from either the emerging themes or priority populations. Okay, not hearing anything now. So I know there's a lot on the screen, and we're not even gonna talk about it today. I just wanted to show you kind of what we're looking at for next week. We were hoping to take some of the health problems, like the top causes of death, and maybe you all want to, you know, keep in mind the top 10. I know diabetes was on there, and some other issues, and kind of look at that. So I see this is great. Local foods, local places touches many of the health disparities for low-income communities of color in Lincoln Park. And I think, Khalida, you make a really good point. I think probably as you were going through some of the things today, you recognize there's a lot of work already happening in some of these areas. And like when Sonia was on earlier, she's doing a lot of work. We've got a breastfeeding work group. The Roundtable has a steering committee that meets about teen pregnancy and prevention and things like that. So there is some work happening already. And like local foods in local places is a plan already put together that it's kind of like a no-brainer of how do we help build and support that plan. So that's going to be one of the things we need to think about through too, like when we put the plan together, what's already happening that we can help support, build, offer support to, things like that. So I love that. So in the next call, we'd really like to kind of walk through, and this is just a sample up here. It's not complete or anything, but when we're looking at cancer, what are some of the risk factors for cancer that are scientifically known to be major risk factors? What are some direct contributing factors, like a family history? You had a mother or a father with cancer, some different things, and then indirect contributing factors. And I think a lot of our emerging themes and that came out are probably contributing factors to many of these top causes of death. And then I think from looking at this in the next call and kind of working through some of these pieces, that we can probably start seeing some areas we would want to focus on. Hopefully we'll see how that goes with that. But the plan is to be able to pre-populate as much as we can of some of these causes of death and this these forms for that, and send that to you in a draft form so that you can make some notes out to the side of things you think are also there from your experiences and your knowledge, and put those in there, and so that we will have some fruitful discussion next Friday and things like that. So that's our goal, to email you before the next meeting. You'll get a link to the calls today, the meeting minutes, as well as the presentation, in case you want to like go through there and look through the presentation from today. You'll have the agenda for the next meeting. The plan is to get you all of these pre-populated with things we know about and that you can kind of respond to and think about for the next time. We'd like to get a copy of the current CHA. Right now, I was able to accept it at 23 megabyte file. It is pretty large. I don't know if all of your emails have a limit on what you can accept. So we're going to email it, but also try to provide another way of getting it, either through Google Docs or another way where you can download that and look at that. It's 300 plus pages, so I know that you're not going to have time to read it all right now, but I'm hoping in the next month you have time to kind of review that. And if there's some pieces in there that you have questions, you feel are missing, things like that, that we can get your feedback on that before we finalize and update it with the local public health system assessment. And we're going to submit that to the state as well on December 31st for final with our new updates to it. So, but I did want you to have the access to that to kind of review and go through that as well. And then is there anything else? Probably go ahead and send you a copy of the current CHIP plan as well, so you can look at that. We're going to talk about, like, what did the 2013 plan focus on, and then how did they transition from that 2013 to 2015, just to kind of give you that historical perspective of why people were choosing to focus on different things, and then hopefully put that context so we can start looking at what we want to focus on in the next, next plan that we have. So. Any comments, questions, ideas for next meeting that we're missing or you would want to know about other than what we've talked about today?
I'm impressed, Jen. You guys worked really hard on pulling this together. A lot of information today, and you shared it as succinctly as you could, and it was pretty clear. So awesome job.
Thank you. Yeah, I know we were definitely at a higher level, like Edgar said, and I do think as we start drilling down into what we want to make an impact on, we're going to have to drill down into what does that look like? What is the age, sex, race, ethnicity, language, cultural pieces to solving that we need to address. And I think Sonia makes a great point earlier too with being able to work a little bit more comprehensively and around when we're addressing the population that we're working with. I think that's really good. And how do we engage them in programs that we have and things that they could take advantage of? We're obviously missing something if we're not getting them engaged some way that we need to re-look at. So I think that's great. So anything else? You guys have been so patient. I really appreciate all of your interaction and your comments and sharing what you know, and asking the questions and stuff and making sure that if we've missed something or that you're interested and you think we need to entertain, that you've done that today too. So anyway, I hope you all have a super weekend, and thanks so much for your time. We look forward to talking to you next Friday.
Thank you, Jen.
Thanks.
Thank you, Jen.
Thank you, everybody.
Have a good weekend.
Bye, Jim. Hope you had a good vacation.
This conference will now be recorded.
Did I already?